everyone. Good morning. This is Dr. Khan, Executive Plastic Surgery. It's a pleasure to be on a Monday morning, and so start of another week. And so a very interesting last week. I just want to go ahead and welcome the new members to the Facebook group page. Remember, this is where we're having like a healthy discussion about what the patients are talking about ultimately, most importantly, and how they are benefiting from the explants. We are going to talk about what the manufacturers or themselves are saying, and what the FDA has said about the implants, and the patients, how they're seeking relief from the explantation. So on the 29th of January, I did a case where the patient had a saline implant on the right side, and she had almost 87 cc's of yellow turbid fluid that was removed. The pathology of it came back as basically fat necrosis. It was dead fat, and inflammation cells that were present within that fluid around that saline implant. And so this is where it was all contained. None of it spilled into the chest. It was done in the en bloc fashion, as you saw on the 29th of January 2025. And this was a saline implant that the patient had. And again, goes to show that the en bloc is the gold standard, and there is no other better way than doing the surgery in the manner that I do, where this is all contained such that none of the internal contents spill into the chest, into the periphery. I want to go ahead and take the time to also discuss one of the comments that I saw last night on the Facebook about, the surgeon, in my patients recover and take like 2 months, 3 months to recover. Now remember, this is a very different surgery. Implant or augmentation in itself takes 45 minutes to 1 hour. And it's a relatively quick surgery, if you will, between the two sides, and getting the patient off the table and being done with the surgery. Explant surgery in itself is a different beast, if you will, where majority of the implants are below the muscle and the dissection is done directly on top of the rib. If your surgeon is telling you that you're going to be able to go back to exercising in 2 weeks, you cannot, with absolute confidence, state that your surgery was the same as my surgery, because there is a big difference between the two surgeries. As you can imagine, would a patient after a tummy tuck be going back, or a thigh lift or an arm lift be going back to their normal routine activity in 2 weeks, 3 weeks? Absolutely not. And this is where, when you dissect off of the rib, and you're dissecting medially, superiorly, laterally, inferiorly, and all the way around on top of the rib, and you have to let that settle, that takes approximately 6 weeks, where the patient has to wear the bra and the binder. And for someone to state that you can be done with a recovery sooner than that, we hear of the many patients who have sought surgeons where the surgery was done under local, and surgery was done in 2 hours, where the patient got supposedly an explant and a lift, and sometimes even fat grafting in 2-3 hours. This is virtually impossible in my mind, in my eyes, that basically this is even achievable unless there are two surgeons operating simultaneously at the same time. So here you have a difference between what I would say complete en bloc, and that care, that sophistication, that respect, that honesty, that integrity, that whole commitment to removing the whole capsule sincerely off of the rib, such that all inflamed tissue plus the capsule plus the implant is removed, such that there is no inflammatory burden left behind. And let's say if the patient had the surgery done today, the patient would get that confidence that all of that inflamed tissue, that capsule, that implant was removed as one system, preferably in the en bloc fashion. And number two, that all of it was tested. And in my hands, it takes the 4 hours. Now, as you will see, you do not want to guess, you do not want to second guess the whole process, and you want to be very confident that your surgeon is going to do the right surgery. If a surgeon takes 2 hours versus another surgeon taking 4 hours, there is a difference between the two. Once you get done with your surgery, you want to have that peace of mind, that confidence, that tranquility when you put your head on the pillow on the day of the surgery, that your surgeon got it all out and it was all tested. And there's ultimately 5 things that I tell my patients to consider and to look at. The first and foremost thing that I find it is critical, and this is again my practice, ultimately the patients can do and choose whatever they wish. If their priority is to go back to work and be done with the surgery and be back to their routine in 4 weeks, 6 weeks, and exercising and going to the gym for half an hour, then I am not your surgeon. And this is where you will not be getting, in my mind, in my expertise, the right surgery. You want to go ahead and get these 5 things that ultimately prove with confidence that your surgeon did the right thing. The first and foremost thing is you want to ask your surgeon, I want to see the pictures, high definition pictures, 1080, 4000K resolution of the chest wall showing complete removal of the capsule off of the rib, and high definition videos, pictures of the chest wall showing complete removal of the capsule and that inflamed tissue, such that there is only good, healthy, viable tissue remaining behind, and that all of it was removed. So that is the first and foremost thing. If your surgeon cannot produce that, there's a big red flag and a question mark. Number 2, you want to be able to get the implants back. So if you had saline implants, you want to make sure that the surgeon did not rupture the saline implants in order to do the surgery. This is very important. I find the many surgeons who basically rupture the implant because they want to approach from a small incision, the whole mentality and philosophy of the explant is lost. Number 3, you want to send the capsules off to pathology, because that in itself is proof what is the size of the capsule, what are the dimensions of the capsule, because anytime the capsules are sent to pathology, they actually document with size, 12.5 centimeters by 8 centimeters, for example. That would be the dimension of the capsule of an average implant. And from my analysis of the many other patients who have gone to other surgeons and incomplete capsules were removed, you will see the pathology samples were like 3 or 5 centimeters, which tells me that not all of the capsule was removed. So number 1, high definition pictures and videos of the chest wall and cutting open of the capsule on the table. Number 2, you want to get your implants back, because the implants themselves, remember, what are in your body, you can certainly hold them. There's not like a contraindication to not holding them, right? If they're in your body, you can certainly see them, hold them, you can get them back, be it from the hospital and certainly from the surgery center. Number 3, you want to send the capsules off to pathology, and you want to see the dimensions of the capsules directly as to what was sent to what was removed. Number 4, you want to be able to see that the length of the incision is not like 2 or 3, 4 centimeters. I have a patient coming from California. Her incision was just 3.5 centimeters. You cannot do an end block through the nipple. You cannot do an end block from a small incision at the bottom of the breast tissue. And this is where this patient inevitably, 100% without a doubt, had incomplete surgery, because you cannot dissect from the nipple areola, or you cannot dissect from a 3.5 centimeter incision and remove what is a 500 cc implant. You have to be able to see medially all the way lateral, superior, and inferiorly. So that is a whole area. Number 5, you want to see the length of time that the surgery occurred. How many patients have I talked to who said that their surgery took an hour and a half? How many surgeons I have seen their operative record that stated that their entire explant surgery plus a lift plus fat grafting 2.5 hours? Virtually impossible to do the explant, where I myself take the 4 hours in order to do the explant alone minus the lift. Fat grafting, as you will see, in my mind, in my practice, is what I would call malpractice. It is bad medicine and hurtful medicine, in the sense that if you will see some of the fat that is given, for example, 100 cc's or 150 cc's that is injected into the breast tissue, some of it will add volume. Some of it will liquefy, and the body in itself will absorb it. Some of it will form clumps of dead fat and nodules of fat, some of which will be partially hardened, and they will be, quote, scattered, fanned out because of the way the fat was injected over the breast tissue. And now I have seen patients that have come to me from all over, from the best surgeons in the country, where they have these fat irregularities. And the question is this fat grafting that has gone bad? Is this fat necrosis? Is this breast cancer? Or is this scar tissue as a result of the dissection up and down? And so this is where now 1 out of 8 or 9 patients who get breast cancer are now worried, anxious. They're literally, lack of a better word, very concerned about potential masses that are present on the breast tissue. And remember, 1 out of 8, that means we saw the Super Bowl commercial last night where they said almost 6 million women who were watching would end up getting breast cancer. That means if you have a stadium full of 80,000 ladies, 10,000 will in their lifetime, 1 out of 8 will get breast cancer. And these are not my statistics. I want you to look that up. And so you do not want to complicate a self-monthly breast exam or a mammogram that might pick up on irregularities. I have patients that have come to me where the breast center did not want to get a biopsy of that mass, which was right next to the implant, because they were concerned that they would puncture the implant. And so there are concerns where you are now putting aesthetics first over cancer. And remember, cancer is real. When you get it, unfortunately, the chemo, radiation, longevity problems that occur are far worse than the aesthetics that one will benefit from. And I'm not trying to scare, I'm just trying to say this is part of that informed consent. And the other thing I want to mention, that patients who have gotten fat grafting to the chest breast area and other areas, you will see that they have had nerve changes, sensation changes, some painful sensations, loss of sensation, hyperstimulation, whatnot else, and you alter the physiology of that area depending on how much and how the fat was processed. So going back to the point, so the length of time is very critical. So if your surgeon is spending 2 hours to doing an explant or 2.5 hours to doing an explant and a lift, I will tell you that's a big question mark in my practice as to why and how that is even achievable, because I myself take 4 hours in my practice to doing the explant in the manner that I do. And the other thing I want to mention is that 6th thing is going to be the reputation of the surgeon. So you will see a surgeon where the previous patients authenticate, they basically certify, they give value to the next patient's perspective experience, so that they know with confidence that the surgeon is going to do it right, the surgeon is going to do it genuinely, that he or she is not augmenting, that he or she truly firmly believes in breast implant, unless they're talking about breast implant, unless they have a web page, they have, remember, this is a type of surgery where, let's say for example, if someone were to get their gallbladder out, I will say this, who cares? They're going to get the gallbladder out in the manner that they do, be it you dissect from wherever you do. Sometimes people get a cholangiogram, for example, whatever it may be, that the surgery is done. Or if you have an appendectomy, for example, the surgeons do the surgery. In this manner, you really want to do your homework. You really want to understand the mentality, the philosophy. You need to understand the surgeon's psyche as to what is his motive, what is the purpose and intent and goal of the surgery. And as you will see, the whole purpose here is as simple as it sounds: removal of not only the implant, but the capsule. The capsule absolutely must be removed. There was another question I saw last night, that do I really have to remove the capsule? And as you will see, there are many patients, and don't listen to me, listen to the many patients who have explanted and the capsules were left behind. They did not improve completely. And then only when they saw another surgeon who removed the residual capsules, only then did the patients improve. So you want to do it right. you want to do it once. You want to see the high definition pictures and videos of the chest wall showing complete removal of the capsule, so that you have that peace of mind, and you want to get that complete workup, and you want to have that bond with that surgeon so that you have that absolute determination that you got the surgery that you asked for. Unfortunately, in today's world and age, you will see no surgeon is truly taught this explant technique. Every surgeon has kind of their own formula within their surgeries. The surgeons have their own philosophy, i.e., oh, the capsule is so thin, I left it behind, or I just cauterized the capsule because I felt that that would be safer because I did not want to remove it and dissect it off of the rib, which is very involved. You will see many surgeons come up with different formulations, different thought processes, maybe and certainly out of the goodness of their heart. But in my practice, remember, the whole goal is not only removal of the implant, but the capsule plus all of that inflamed tissue around that capsule that must also go, because if that is left behind, the patients don't recover. 4 weeks ago, we saw the patient from Austria. In a month, we will do a Facebook Live with another European patient who got an Explant and Bloc. It was done very comprehensively, but that inflamed tissue around the capsule was left behind. And in those patients, as you will see, when that inflamed tissue was removed, only then did they improve. So you want to do the surgery right, where not only the implant is removed, not only that capsular tissue is removed, but also the inflamed tissue. 3 weeks ago, I did a case. A lady had implants from 1991, and these were the ruptured silicone implant. There was a lot of inflamed tissue, and so you saw that silicone had leached out not only into the capsule, but into the periphery around that tissue that certainly looked inflamed. It was nodular. There was extra capsular rupture, and so it was not going to be complete, where if the implant capsule was supposed to be removed, that extra capsular tissue where that extra capsular rupture had occurred, that tissue certainly needed to be removed as much as the capsule plus the implant for the patient to recover. And so this surgery is more about etiquette, sophistication, about the care, and not about, oh, well, I want to return back to work in 2 months and be able to exercise at the gym. You have lost the whole purpose of the explant then. You do not want to be compromising your recovery. You want to be absolutely certain that all of that capsular tissue plus inflamed tissue and implant is removed. Your whole goal must be that absolute determination that you're going to do the surgery once and you're going to do it right. You're not going to be looking at anything but that video and high definition picture and all these other things that I mentioned. And I will go ahead and mention this again, that the high definition pictures and videos of not only the chest wall, but also the opening of the capsule on the table and videos that needs to be shown. Number 2, the capsules must be sent to pathology to show how much and what the capsule size was. Number 3, the implants need to be returned to the patient so that the patients know that the saline implants or the other implants were not damaged. The length of the incision must be the diameter of the implant, maybe more. Number 5, the length of time of the surgery is critical, I find. The incision start time and incision end time in my practice is a very good indicator as to how seriously the surgeon removed the capsule off of the rib. Remember, this is not a surgery about speed, it's a surgery about precision and care, and that absolute faithful, religious, honest determination by the surgeon that all of that capsule is going to be removed. And number 6, the reputation of the surgeon is key, such that you know with confidence that she is a firm believer in explantation, that he or she does not augment, and that authenticates that the surgeon is going to do it right. Remember, augmenting takes 1 hour. To remove the implant takes me 4 hours. This is minus a lift. And I will tell you, for the surgeon to give up augmenting and just to explant, financially, the surgeon can be doing 3 augmentations in the time to doing an explant. Number 2, the physical ability to dissect off of the rib, that is also not to be underestimated. It's physically very demanding to be standing there and doing the surgery very meticulously. It's very absorbing and mentally, physically consuming to doing the surgery. And then also sometimes you have to deal, the third thing, which is very important, you're dealing with the other surgeon's problems or other problems that occur as a result of the implants. For example, a ruptured implant. So the capsular contracture, extracapsular rupture, the surgeon did a poor job previously because he was not board certified. He went through the belly button to put an implant, certainly complicates my surgery. Or surgery was done very well by a board certified plastic surgeon, but now the implant malpositioned itself. Or in this case, there's a lot of gel leaching and now a lot of inflammation from the textured implant that has occurred. So there are so many, or patient who had history of radiation, patient who had history of multiple surgeries. Remember, that is a very difficult situation for the surgeon to dissect. And so if the surgeon is explanting, you can see that he or she has their true commitment. Unfortunately, in today's world and age, you will see, and this is very real because I have talked to those surgeon groups, where within the group you have 3 surgeons, for example. 2 surgeons are augmenting like crazy, and another one is dedicated only to explant so that they can market that surgeon better. So you want to be very careful with that as well. And again, if you look at and factor in each one of these points, you will get your surgeon. Do your homework. Do not rush into the surgery. Do not be motivated by the fact that another surgeon takes insurance. I will tell you, if I started taking insurance, I would file for Chapter 11 by Friday. Simply because the amount that the insurance is reimbursed is essentially nothing. They will pay anywhere from $600 to $1,200, if at all, for a surgery that they do not want to even recognize and they do not want to even pay. And insurances in itself, as you will see, is a big scam in itself. The insurances don't want to pay anything for anything, and they certainly pass the burden on to the patients. They do not even have an ICD-10 code. And this is essentially a failed recognition of what is a real problem by the medical community, the scientific community, and by the surgical community, where no one wants to give recognition to a problem that is very much real that led to the ban of the implants themselves. The other thing I want to mention here is, you know, there was a patient that mentioned that I was requesting for an MRI or an ultrasound. And again, that is very... I use the word wrong for the patient to state that I request for an MRI or an ultrasound for all my patients. In that patient's case, she likely had a rupture of a previous silicone implant, and there are silicone granulomas that form. There might be some spillage of the silicones into the lymph nodes. There might be other problems that that patient specifically had in regards to her previous multiple silicone implants. So for that reason, going into the surgery, I require MRIs. So as you will see, in majority of the patients, 99%, I do not require an MRI because I always assume that the implant is ruptured till proven otherwise. You do not want to go in rushing through the surgery if you're a surgeon and finding out that the implant was ruptured, and now you're taking care of a problem that is going to become a much bigger problem. And so this is where you have to do your homework. You have to understand this process very well. You have to follow on the Facebook, and if you follow on the Facebook initially, you will be overwhelmed. There will be a lot of information, but after some time, you will see that there's only a series of questions that you can ask. As you will see, I want to go ahead and just highlight, you know, there are some surgeons who state, I will end with this, you know, these are the warnings by the manufacturers, by the FDA. As you will see, this is an advertisement at the back of our journal that we as plastic surgeons read, and you will see, warning, breast implants are not considered lifetime devices. The longer people have them, the greater the chances are they will develop complications, some of which will require more surgery. And then the other thing I want to mention, the third point here, patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. So if someone says, well, breast implant illness doesn't exist, well, I guess what? Here's the manufacturers and the FDA just stating that it does exist. And then it says individual patient risk for developing these symptoms have not been well established. Period. Some patients report complete resolution of symptoms when the implants are removed without replacement. And so this is where they're telling you if the implants are removed. Now, in my practice, this is where you will see, if you follow me on Facebook, you want to do the surgery, and I'll end with this. You want to do the surgery once with confidence, with determination, and with that peace of mind that the entire implant, capsule, and that inflamed tissue is removed, number one, and number two, it is tested, and that you have the high definition pictures and videos showing that exactly that was done, and that there is that complete confidence that your surgeon is a firm believer, and that when you look back at the surgery, you're not going to be second guessing your surgeon. If your motivations are that you're going to have the insurance pay, then I will tell you from my experience, the goals of the surgery will not be met. If your determination is that you're going to be back in the gym in 4 weeks, 6 weeks, and that this surgery should be a breeze, that you will not be recovering from this surgery, at least in my eyes, in my practice, in the manner that you would and should, because of the extent of the dissection of the capsule off of the rib. That recovery process takes 6 weeks, and as you will see, the freedom is certainly there. Within a week's time, I would say 80–90% of my patients, if they're off the pain meds, their confidence level is there and they feel comfortable, and their gut and sixth sense tells them they can drive. Certainly they can drive. Within 2 to 3 weeks, I would tell you, those ladies who have a desk job, they certainly can be going back to work. But those patients, for example, who work in the ICU as a nurse, who are flight attendants, you will see that's a lot of force, i.e. that they have to use to move the patients up on the bed, or if a patient is, they have to work around the patient. So you have to be able to, when you go back, not hurt yourself. And so this is where, just like after a tummy tuck, you cannot be going to the gym and doing bench presses and sit-ups. You have to respect the recovery. You have to respect the length of the recovery. And so if your motivations are that you want to go back, you do not want to do an incomplete surgery where now you're going to be second guessing your surgeon, you're going to be going back for another second surgery because you did not recover completely. And you want to listen to the surgeon. You do not want to listen to patients, because the patients are not surgeons, they're not doctors. So if I need medical advice, I would not dare talk to another patient and recover and listen to the patient's recommendations, because the patient is not the doctor, they're not the surgeon, they didn't operate. 3-4 weeks ago, I operated on a lady with 775 cc's ruptured implant. That's a very different patient than the 250 cc implant above the muscle that I did last week. Or another patient where she had a capsular contracture and smaller implants, and the surgery went very well because of her good surgeon who did the surgery. So you want to listen to the surgeon who did the surgery. You do not want to, and I say this, even listen to the nurse or the circulator or anyone else, because they were not doing the surgery themselves. And this is why I'm very much hands-on before, during, and after, because I only know what happened in the operating room, and every patient's care is very much individualized and not referred to another person post-op now that the surgery is done. So you want to get the peace of mind. You want to do your homework. You do not want to rush into the surgery. You want to talk to the surgeon's previous patients, and you want to get that absolute peace of mind and content, such that once your surgery is done, you have that happiness and peace of mind that you are on the road to an optimal recovery. So do your homework. This is part of the informed consent. Hopefully you found this informative. Please share and discuss, and I wish you the very best till we meet again. This is Dr. Khan, Executive Plastic Surgery.